Everybody. I'm really happy that we're all here, and I really appreciate your patience despite all the hiccups that we've had. So without wasting much of our time, we're going to go ahead now and start the program. So we already have Stephen in the house, so we'll go on now. So today's webinar is going to be based on using R for healthcare improvement. And our speaker would be Stephen, who is going to be introduced by Marvelous. So I'll start by going through the agenda. So the agenda for today, we're starting late. So it's going to be, we've already accepted participants into the webinar. So we're really grateful that you're here. Thank you so much. So I will now hand over to Marvelous to introduce the co-organizers and the speaker to us. Marvelous, are you ready?
Oh, yes, I am.
Okay.
Yes, good morning, everyone. We apologize for the hiccup and the technical issues we ran into before the webinar started. Without wasting much of our time, I'll just kindly introduce to you the co-organizers. I have with me Mrs. Bilikisu, who is a business data analyst. She is the convener of the Our Ladies Abuja group, which is put together for interested persons who like to use R for public health and several aspects, just playing and exploring areas in which R can be used for development. And myself, I am Marvelous by name. I work as a research analyst. I'm also a member of the Our Ladies Abuja group, and I work together as Mrs. Bilikisu as the co-organizer of this webinar. So briefly, I would like to introduce our speaker, Dr. Stephen Balogun. Dr. Stephen Balogun is a public health expert. He is a project manager, a data scientist, and a quality improvement expert with over 10 years of experience. He has worked with several international non-governmental organizations in the private and public sectors. Also, he has led several quality improvement projects in the country and beyond. He has worked with some NGOs like Global Fund, AIDS Healthcare Foundation, PEPFAR, Vitamin, Angels Project, and so many others. So we are glad to have you here, Dr. Balogun, and it will be a pleasure learning from your wealth of experience on how we can use R for improvements in the healthcare system. So you're welcome, Dr. Balogun. Over to you, sir.
So now the training session will start immediately with Stephen. So I'll hand over and I'll take out my screen now. Thank you so much.
Okay, thank you very much, Bilikisu. Thank you so much, Marvelous. I'm happy to be here. Thank you for all our participants, and thank you for staying by despite the glitches. So I'm going to go ahead and share my slides now. Host, can you please enable me to share my screen?
Yeah, you can go ahead now.
I still don't have this sharing right yet, so I'll let you know as soon as I have it.
Okay, now, yeah. You can go ahead now.
Yes,
Okay.
just
thank you.
Okay. All right, so once again, my name is Balogun Stephen. I'll be presenting today on using R for healthcare improvements. Just some of the projects that I've done are using R and how I find it useful. Basically, we can't talk about all the ways in which we've been able to use R, but we talk specifically on two areas that over the last years we found R very useful to improve our healthcare performance. So this is about the outline we'll follow today. I'm going to tell us a little bit more about me, then what I do specifically related to the healthcare industry, what the Nigerian National Depository mean, and how come we're talking about it today. And then the Tidy NDR package and the Achiever app, now they relate to the Nigerian National Data Repository. We're going to take some questions and then go to the demo and then come back and take further questions. Okay, so Marvelous has already introduced, I'm a medical doctor. I work in the public health space, quality improvement and safety experts. I'm sometimes a data scientist, so data science is practically more or less like one of those things that come relatively low, because the clinical experience takes most of my time. But I'm glad I've been using R since 2014, so that's been a while, and I've been able to make some progress over the years. There is something we call the R for HTS that I founded with my brother, but you realize that the page is not as active as you would want. And I have a personal website too. Bilikisa has already shared the personal website, so it's about the same one, even though it's also not frequently updated. And then I have a Twitter handle at Epidog. So if you want to follow me on Twitter, yes, please go ahead. So, okay, so what I do, I work specifically in the developmental sector and the HIV/AIDS industry. And globally, I just want to tell us a little bit about that, give us a bit of snippet so that when we're discussing, we'll understand a little bit more as to how the use of VAR relates to the industry where I work. Okay, so globally, there are about 38 million people living with HIV/AIDS. Nigeria accounts for about 1.9 million of these people, and we already have about 1.3 million of them on treatment. We also know that there is a global move to ensure epidemic control of HIV by 2030 with the 95-95-95 target. So the first 95 talks about, let's have 95% of people who are living with HIV to know their status. Okay, we do this by basically by ensuring that people have HIV testing done, at least 95% of the people. And so if they are positive, they are aware, and if they're negative, they will try to remain negative. Okay, so 95% of those who are aware of the status and are positive, we want them to be on antiretroviral therapy. So ART is antiretroviral therapy because it works, and we now know that when people use it consistently and correctly, it helps them to become what we call virally suppressed. And if their viral load is undetectable, then they might not be able to transmit it to others. That we also already know. And then 95% of people on therapy, like I said, we want them to be virally suppressed, specifically as much as possible for the virus to be undetectable. So we're going to talk a little bit more about some of this in a bit, but I'd also like to quickly mention that, yeah, we have indicators to measure progress, performance internationally, and that's why the UNAIDS release the performance dashboard like December of every year. The PEPFAR program, that's the United Nations institution that supports HIV programming and other programs globally, have a group of indicators for HIV, and they are grouped into about 5, the ones that are related to helping to prevent HIV, the ones that are related to ensuring people are aware of their status by having them tested. And for those who are positive, we have a few indicators that we call the treatment indicators and the viral load indicators. So the viral load indicators, I'd like to talk a little bit more about this. So it's more of, for Nigeria, we want people after they have been on medications for 6 months, we say they become eligible to have their first viral load result. And then subsequently, we want them to have the second one after 12 months of treatment and then annually after that. So when people become eligible, we want to know what proportion of people who are eligible for viral load have had a test done. Then the next one along the cascade is, okay, these people have had their test done. How many of them are virally suppressed? So that we're able to say, okay, X number of patients are on treatment, Y number of people have achieved viral suppression. And then we can look at how we can improve the care and treatment for those who probably might be unsuppressed due to a whole lot of other factors. So the last indicators on the PEPFAR list is what they call the health system indicators. We'll practically not be talking about the health system indicators in this particular presentation today. So this is just a summary of what the unit 395 stands for. I think we've mentioned all of them. Again, 95% of people should know their status. 95% of those who know their status and are positive should be on treatment, and 95% of those who are on treatment should be orally suppressed. Okay, so coming to the National Data Repository now. I'm hoping that along the line, or maybe I'm really just not aware yet. Right now, I know the National Data Repository, it's a repository of the identified patient level data from facilities across the country, specifically for the HIV program. So it has a public dashboard that is visible, that you can visit using the link in this slide. I've shared the slide in the meetup page, but you can also get to look at that after this presentation. So it has a public dashboard. It says that there are over 1,000 health facilities across the country that report on the platform and has over 1 million people who are on treatment. You can get all this information by visiting the public dashboard. Unfortunately, it also has a firewall, so if you need more information, you'll have to be able to log in to access this information. So, but for the bulk of the information that is available in the public space, I think you have good enough information that you're able to appreciate exactly what it does there. Okay, so that's about the National Data Repository. And this is a few of some of the things that it looks like. So how does the data get to the National Data Repository? So it's more of from the health facilities. Some of them have still use, they're completely paperless, so they use full electronic medical records. A few of them really don't. But for those who don't use electronic medical records, they still get to enter into the computers. Who are not completely paperless, they still enter into the electronic medical records and then upload online. The NDR ingest all the available data and then allows you to be able to download patient level line list if you have the login access. So we will be looking at how this really helps to improve programming, but we'll be using simulated data because the access is restricted, so we won't be able to use the real NDR data, but we'll use the simulated data just to be able to demonstrate exactly how this works. Okay, so why are we talking about the NDR right now? So, and it boils down to one of my favorite quotes, one of my favorite sayings that says, to measure is to know. If you cannot measure it, then you cannot improve it. Sometimes ascribe to Peter Drucker, sometimes to Lord Kelvin. But basically, it's because the NDR allows you to be able to see patient level information, though they are identified, meaning that you can use this information to know exactly who are the people that are performing well, where are these people coming from, or the facilities where these are happening, where are the facilities, where are the patients that are having challenges, and how can you tailor the care and treatment response to be able to support these people better. But naturally, people, of course, downloaded line list, or the line list you have access to is in the form of a CSV format. So it's a flat file. People practically use spreadsheet applications to play with this, and then it involves a whole lot of calculations that not everybody is quite familiar with. And then you have maybe relatively specialized group of people who just look at these things, and especially for those who are in the clinical sector, this information becomes relatively less available to them. So they're not able to use this information to tailor the care and treatment to the specific needs of people. And sometimes even when this information are available, they're just aggregates. And it takes a whole lot of effort to start looking at, okay, we know that there are gaps, but where specifically are these gaps coming from? Who are the people specifically responsible for this? They're just really not able to answer some of these questions very easily. The other thing is about the routine analysis, where people have to periodically do analysis. And imagine if you have to do point and click every time for something that takes 2 hours, and it's something you practically do weekly. Then now let's imagine that you multiply that by 10 because you are covering 10 facilities or thereabout. It becomes relatively quite tedious. So we thought about all of these things and how we can automate these processes. So we came up with what we call the Tidy NDR package. So it's just an R package to work with the NDR line list. That's the National Data Repository line list that you get. Automate the processes, make the process as seamless as possible, as easy, help people to focus on the work rather than the methodology and things like that. So I really, I love this picture from the Allison host group of pictures. Basically, she was using it with respect to environmental data, but I think it speaks about the same thing with what we do in the public health space. So you have the public health data that gets reported online on the National Data Repository. You have access to this line list, so you have to import this into your R, tidy, transform, and then visualize this. So basically, this is the process we also thought about when we were working through this process. How do we just keep it in line with the traditional tidy workflow that we are all probably familiar with already? So we built it in line with the tidyverse methodology, the tidyverse group of packages. So it becomes relatively easy. And the good news is that I'm just amazed at what the people who use the tidy, who develop, the developers of the tidyverse package put out there every day, every time. Our learning R will probably just really not have been so easy for someone like me, if not for their efforts. I remember in the early days when we have to learn the GSOP, the grep, and the rest of them are functions. They were relatively quite tedious for me. I really don't have significant background in statistics and things like that. But the good news is, despite all of those things, you're still able to use R and make significant progress and come up with something like this. So like I said, we've just built it in line with that. So last month, in the month of March, we were able to put it on CRAN thanks to the resources online, the advanced R, the R package books by Adley Wickham, and a whole lot of other resources. We were able to get it out there. So you can install it directly from the CRAN. So if you want to follow the demo today, I will strongly encourage that you go ahead and just install it. The developmental version is also available on GitHub. I generally love to use build vignettes when I'm using GitHub because I realize that the default really doesn't install the vignettes too. And vignettes are generally I find them very useful. So even when I'm installing developmental versions, I just hope that the developers put the vignette out there, and I go ahead and install the vignette along too. So we're going to be using the simulated data that I talked about. Is available on GitHub. It's also part of the link that has been shared. So if you want to go ahead and download straightforward, please go ahead and download the simulated data. Is about 20 megabytes. So I'll be using the local version so that we don't have issues, run into challenges with network or things like that. And I probably just want to encourage you, if you can download it and then import it locally too. I think that makes a whole lot of sense. So in general, in summary, it's all about, yes, we know there are so many ways you can do analysis, even without a tidy NDR package, but it's about, why do I have to use the first formula for variance when I can just use by X, for example, in R? Why would I have to go into each of my vectors minus the mean divided by this when I can just cover X? And when I was putting this out there, I had to think 2-3 times before I remember the formula for variance, because it's all about making life easy, right? So you can imagine how using by X has made life very, very easy instead of having to put all those initial formulas out there. So that's the whole mentality behind the Tidy NDR package. Not everybody out there, especially in the health sector, will be developers, will be interested in coding, but we can make it relatively as simple, as user-friendly as possible. Maybe they will get to the benefits at that moment will outweigh a steep learning curve and things like that, and they're able to take this off and then use it to improve the process along the line. So basically, the package is grouped into about 3 different functions, just in line with the workflow that we've talked about. A single function that helps you to import your data into R, a whole group of functions that we call the treatment function. So I'll just take about a minute or two to talk about what these treatment functions mean. So these are relatively standard names. So it's names people who are already in the sector are quite familiar with. So when they see something like TX_new, they already seem to know what it means, which makes it a whole lot of user friendly. So TX new is just about telling you what proportion or who are the new people, the clients, the patients who just started treatment within a particular period of time. So just to clarify, also one more thing is that generally in the sector, for most of us in the programming year starts in October. So our first quarter is generally between October to December. The second quarter is January to March. And then the third quarter is April to June. And then the last quarter is July to September. Okay. So I might want to be interested, for example, who are the people who started treatments in the second quarter of the year? That's between January and March. I might also want to be interested how many people are still in treatment altogether, meaning that they're still actively taking their medications, even though they might have missed their appointment. So missed appointment is calculated in terms of people who are scheduled to have come for their refill, but missed, but are less than 28 days. The moment is more than 28 or more days from the date of missed appointment, they become what we call, we say they have experienced interruption in treatment. Okay, so that is what the TXML calculates. And then the TXML outcomes try to figure out why did they experience interruption. Is it because they are dead? Is it maybe because they got tired of taking the medicine and there's nothing else you can do about it? Or because they have decided to move on to another facilities, or a whole lot of other reasons. So you want to really be able to figure that out. And then the RTT talks about those who already became IIT, so they've missed that appointment for 28 or more days, but for some reasons they decided to come back to treatment. Okay, so you are able to also count that. And the MMD talks about the duration of medicine that was dispensed during the last clinic visit. Was it 1 month, 2 months, 3 months, 4 months, or thereabout? I just tried to quickly summarize a whole lot of this. I hope it's not too much functions and we're able to just follow. Please let me know at any time. Even though I'm having issues accessing my chat box, because okay, I have it right now. Okay, so please, if you have questions, comment at any moment. Let's just put it in the chat box and then I'll try to address them as soon as they come up. Okay.
Okay. Hello. Sorry, Doc.
Yes, please go ahead.
Okay, please, so that we'll have an organized session, let's just have the questions coming in on the chat box, then we'll attend to them. Maybe when you're ready for us, we can take like 15 minutes out of your time, then you attend to some questions, then you can continue with your presentation. So just
Perfect.
let me know, let me know when you're ready.
Perfect. I think we have 2 question and answer period sections, so we can take them during about those times. So please, like she said, let's just drop them in the chat box and we'll attend to them during those periods. Okay, so I've already talked about the viral load functions. We want to know how many people have been on medications for more than 6 months. The denominator is how many of them already have a result. The numerator talks about how many of them, of those that have a result, how many of them have a viral load result that is suppressed. So suppression is at a level when the viral load, a person is said to attain suppression when the viral load result is less than 1,000. So when they do the viral load and the count per mil of blood is less than 1,000, for this part of the world, the person is said to be suppressed. Okay. And unsuppressed is when it is 1,000 or more. So for those that are unsuppressed, we know that there are tailored interventions to be able to help them achieve viral suppression. So it becomes very important that at every single point in time, you are able to know who are the people that are unsuppressed, because there are already proven intervention strategies that can be used to help them achieve suppression. We want to be able to know how many people are supposed to have viral load samples collected at any point in time. You want to know of those whose samples have been collected, how many have had the results. These are the ways you specifically address the needs of each patient. And it's not just about giving you aggregate summary, which I think is the beautiful thing about the package, is it helps you to be able to identify the specific clients. Of course, they identified information, but when you now go back to the facility EMR, you are able to pull the full information about these patients, and then you know where exactly the gaps are coming from for tailored interventions. Okay, so the summary functions just help you to do your aggregates, even though one of them is called disaggregate. We'll see how that works in a bit. So 2 vignettes came with the package. I think they beautifully summarize essentially what the package does and how the package is really very useful. The good thing about this is that I'm also aware that Nigeria is not the only country that has a data repository at the national level for the HIV program. It's probably many countries across Africa also have this. So it becomes very useful if the ways we can learn from each other, see how what they are doing helps us to improve what we are doing, and what we are doing also helps them to improve what they are doing. But this is one of the ways in which we try to do these things. Okay. So that's about the Tidy NDR package. The second one we talk about is actually not a package, it's a Shiny application. In fact, the Shiny application was built before the Tidy NDR package. So what we did when we were building the Tidy NDR was just to aggregate some of these functions and make them available out there, so that they become reproducible and every other person out there can utilize. And I also have to say that I had 4 wonderful people with me who contributed to the Tidy NDR package. Unfortunately, none of them is on this platform with us, though a few of them really wanted to join. So the Achiever app, like I said, is more of, okay, a package is good, but we felt a dashboard is going to be a whole lot better. Even though the Tidy NDR package makes coding a whole lot easy, generally people who don't have any programming experience like we have, when I mean programming now, computer programming experience like we have in the industry, will probably just like something like a dashboard where they can just click a few things and get the information that they want instead of having to code, even though we know that there are benefits of coding as opposed to the dashboards too. So we have that out there too. It's still a work in progress, learning from a whole lot of things, how to make it faster, smart, and more reproducible, things like that. So the good thing about it is that unlike the Tidy NDR package that works with the line list from the National Data Repository, recall that I mentioned earlier that it is the facility electronic medical records that get uploaded online. Now, the format and the appearance of the NDR and the EMR data are significantly different, okay? And sometimes we have issues where the EMR has some information that is not on the NDR, and occasionally information that are on the NDR that are not in the facility EMR. So the Achiever apps helps you to be able to look at these two side by side for a particular facility or state or even the country program, and you're able to figure out where are these discrepancies coming from. Are these two speaking to each other, or do I have what we call data quality issues that is not allowing one of the database to speak or to be in concurrence with the other one? Then not just to tell you if these are happening, it also helps you to be able to figure out where are the issues coming from, who are the people, or what are the things responsible for these discrepancies, so that you can go back and run your diagnosis, figure out why the discrepancies exist and what needs to be done to rectify them. So these are some of the ways in which we have been using R. So this is how the Achiever app looks like. We try to create a login. So you have to have a username and a password before you're able to access it. And then it has a whole lot of tabs as we look at in a bit. So this is also from the simulated data set that we'll be looking at, where we're simulating data from 10 different states in the country. So it has the map with a quick glance summary that can tell you what is happening across these places. And then you can put your cursor on each of the map areas, and then it gives you more information. And then the performance helps you to know, okay, at facility level, at state level, where are these gaps coming from? Who are the best, which facilities are the best performing that we might learn from, or thereabout, which facilities are not so well performing that probably needs more support. So you can imagine how this really becomes very useful for somebody, for example, who is providing technical assistance from the federal capital to states who are scattered, and facilities who are scattered across the states in the country. You cannot always be there with them, right? But it gives you an access to rapidly visualize the information, the data that is coming from these facilities, and not blindly providing technical assistance or not able to monitor or track the outcome of the technical assistance that you are providing. So the NDR is always there. You can access it from anywhere. You can request for the facility to send an EMR report. When you get it, you can just put it into the application and then it shows you how it's looking like. So it really does become very handy. And this has really helped us in a few ways. We have two conference presentations. One was presented last year about how this application really helps improve programming. And we have another one that has been accepted for conference presentation sometimes in July this year, basically based on the things we learned from using the Achiever app and how that's helped us to improve programming. So basically, this is the background information that I'd like us to have. This is the theoretical part. So I'd like us to take a few questions, if any, before we go ahead with the demonstrations. Thank you. Over to you, Velikis. Hello,
Okay, right
Velikis.
now we don't have much on the chat box. So I don't know if anybody has any question and you want to kind of say it out, you can unmute yourself and go ahead. So you can go ahead and ask the question now. Okay, while we're waiting for participants to ask your question, I would like to ask a question here. You've really done a lot of work and it's really awesome what you've done so far. So I want to ask, as a kind of motivational answer, you're a medical doctor by profession, and now you're doing something like a gig, kind of. So I don't know how easy what is for you, or were you mandated to learn R before you can be kind of comfortable working in the industry in which you are now?
Okay.
Share your experience and let us know how the journey so far. I would love to know that.
Okay. All right. Thank you for that wonderful question. I think the first is to say there was no time at any time that I was mandated to learn R. At no time did that ever happen. And basically, the truth is, I don't work. I'm in the clinical sector. I'm in the clinical field, meaning that I am not one of the tech guys that run analysis or anything for any of the institutions that I've worked with. Okay, I'm not in the monitoring and evaluation unit. I'm not in any of those sectors that is into coding or programming. I'm more clinical than any of those. I'm just purely clinical, if I can put it that way. But the motivation has always been way before I even joined the public health sector. I started even while I was still in the clinical field. It's about wanting to be able to deliver the best services, high quality services to your clients. And the good thing, my favorite quote that I put there is that even while you try to do all of these things, when you try to give in your best and the rest of them, there has to be a way for you to measure exactly what is the output, what is the outcome from all the efforts that you are putting in. It is a different thing to have the best of intentions and to always want to give the best, but it's also a different ballgame completely to measure if yes, your inputs are giving the outputs as you expected, as you wished that they would be. So it's more of the desire to always implement quality, the desire to always measure safety that drove me into learning data science. Because to me, I always say that behind all of this is the ability to understand the data that you have, make sense of it, and use that to improve your performance. We almost always say when you want to improve something, what's your baseline performance? What's your target? How are you able to use your baseline information to identify where the gaps are coming from and take pragmatic approaches to solving these things? Somebody has to be in the middle that understands both the clinical, the monitor and evaluation and the rest of them. Because and with my friend, my brother and a few other people, we agree that maybe the people who need data most are more or less like the clinical team because they are the ones who are always implementing. I think this is one of the reasons why I learned it. So I'm generally saying in any field where you are, learning data really shouldn't be restricted to a few people who probably are the data experts. You might not have to be the expert in your section, but if you really, really want to understand what is going on, how to make things get better, then you need to understand the data that is coming from your institution, from your organization. How gives you that opportunities? So I took it and I'm still taking it.
That's interesting. I'm really amazed by the work you've done so far with your team, and I think I'm saying the same thing for every other person that is on the webinar today. So if we have any other question that we want to ask, please let's kindly shift it to the chat box. Then we'll continue after this. So I think.
Yes. So thank you. So I'm going to end this presentation now. Just permit me to stop this so I can share the other slides. I am hoping that the demo session will probably not take us more than 30 minutes. By the way, I'm using dark mode for my R Studio. Generally, I'm photosensitive, so I hope we're able to see and it makes sense to us. My Outlook is practically the same standard R Studio Outlook. I've not changed any of them, so you still find each of the panes where they are by default. So my scripts are on the top, my console is below here, and then my outputs, we see them in your environment. The top right, my files, and the rest of them are on the bottom right. Okay, so we're going to start right now. If you like to follow, I'm assuming that you already have the TidyNDR package installed. If you don't have it yet, please, it's just install.packages, TidyNDR. You might want to put dependencies equals true. Okay, so we'll just go ahead. I've tried to put this so that we can be as fast as possible. So we try to just follow a few things that on an average might be one of the things I want to look at in a day. So the simulated data set contains data from 10 different states, random selection, 10 states from the country. So we're going to take a look at that and we ask ourselves a few questions regarding the data, okay? So the first step I'm going to take is to load my package. I'm going to call the library TidyNDR We try to make it as verbose as possible, thanks to the tidyverse packages again. You realize that the more messages you have, the probably better for everybody. So it's relatively quite verbose in that regard. So like I said before, I'll be using the local file path. So if you have it downloaded already, please just state your file path too. If you don't have it downloaded, I can pull the link for the one on the GitHub, and then you can use that again. Well, it's already in the slide that has been shared in the group page. I don't know if Bilikisu might just want to help me drop that again in the chat box for people who might not have had it before. So I'm using the example file.
I'll do it.
Then I'm going to import it into our using the read_ndr function that we talked about. Now the benefit of the read_ndr function is it's basically built on a few of the functions that we already know for importing CSV files, except that it's nicely formatted. It formats the names for you. It ensures that the column variables are not guessed. So you have the exact column variables as you want them to be, nicely formatted. And the one thing the NDR line list gives you is that just like every data that we talk about, and Adley Wickham's favorite quotes, every messy data is messy in its own way, right? Something like that. The NDR data is actually quite messy. So cleaning is actually quite tedious. So the read_ndr function does not only just import it for you like that, it does a little bit of cleaning, especially in terms of the column name functions, in terms of having consistent column types. So you always have consistent column types, hopefully across the different computers and the different operating systems that you might want to run it on. So we just do that right now. So we have the read_ndr. It contains about 100,000 patients' records. Some of these patients generally are no longer in treatment. They're probably patients who started medication several years ago. Some of them might have died. Some of them, other things might have happened to them, and they're just really not taking the drugs anymore. But all the records are there online, and that's the good news about the data repository. So that's all the records since practically when we started collecting data using the electronic medical records in the country. So the TX score now helps you to answer a question like, how many people of these 100,000 that we talked about, how many of them are still actually taking medications? So if we run that and we ask for the number of rows, then it gives us the number, right? So we have 74,461 that are still taking meds. So it helps you to know, oh, of the 100,000 people that have been started on medications across these 10 states, just 74,000 of them are still on treatment. Roughly, that's about 74–75%. It gives you an idea of what we call the retention in these places, how many people have continued to remain on lifelong therapy across these places. Okay, so the next thing, though we have already answered that question, is that we might want to ask ourselves, okay, I know there are 74,000 people who are still taking medications. I know the total number of observation is 100,000, but how many states? So we're going to use specifically the deep layer function here, the distinct function. Okay. I guess I messed things up. So I'm going to do this again. So how many states? So we have the number of states, the names of the states, 10 of them. Osun, Katsina, Oyo, for those who are familiar with the states in Nigeria, these are the states that have been simulated, okay? So we know that these numbers are coming from 10 different states. So specifically, I want to focus on one state. You might want to choose another state if you are running this with me. I'll be taking a look at Lagos. Let's say I am the person providing technical assistance to Lagos State, but I'm based in Abuja and I have access to the NDR line list, okay? So I'm able to have more information about what is happening in Lagos. So I'm going to take Lagos State and look at how things are going in Lagos State. So the first question I'm asking myself is that in the month of May, how many people am I expecting to come for their medications? How many clinic visits are scheduled for me, for example? So we're able to look at maybe our logistics. We're able to look at every other thing. When I mean logistics, the medication logistics, every other logistics that we need to be able to plan for these people. So we're able to look at it together, and then I'll just run that. So it takes, of course, the data, and then you're able to supply from what time to what time you're interested, and in the states. Okay, so I'm going to change this to Lagos because I have agreed that I'm going to be taking Lagos as my state. Okay, you might want to take Benue or any of the other states, that's fine. So if I run this, then I'm able to tell myself, oh, I'm expecting 572 clients to pick up medications in Lagos in the month of May. And then we can use that information, run with it to make sure that we have everything that we need to take care of these 572 clients when they come. Okay. So, okay, 572. But what is the total number of clients that are active in Lagos? I want to know. It tells me that it's 6,318. So from this information, it does roughly look like, okay, if I divide 6,318 by 572, I'll get 12. So if I divide 6,318 by the number of months in a year, which is 12, I'll probably get something like 572. So it doesn't look like May is a rush hour, a rush month or something like that. It's more or less like the average number of patients that I expect. Because the other thing we know in the program is that we have some months where you generally have higher number of patients coming for clinic medications. So you need to also be aware of this ahead. So you're able, like I said before, to adequately prepare for them. All right. So I now know the number of people who are active, who are on treatment in Lagos. I've decided to save that as Lagos current. I've assigned it to Lagos current because I want to work with this in the later part of this demo. So the same thing now, I know that of course, out of these 6,318 clients who are active on treatment, how many of them have been on medications for more than 6 months? And so have become eligible for what we call viral load. They should have had a viral load sample collected and results documented, okay? So it tells me that it's 5,986. Let's not forget that, or maybe I need to just quickly pull that out, is that this actually is not giving you the functions on itself. It's not giving you aggregate information. It's actually giving you patient level information. So that's why I'm having to call the enroll function to just tell me exactly how many are these people. The patient level information becomes really, really very important, which is what we'll see in a bit, because as you can see here, it's not only telling me that they're all from Lagos State, it's also giving me information about the local government, where these people are coming from, the facility where they're coming from, and I have a patient level identifier that I can use to retrieve the EMR records if I need this, or the hospital number. Like I said again, these are all simulated data sets, so these are really no real patients out there. But it's just following the structure of the information that is available on the NDR line list. Okay. So I can want to look at the results, and then it tells me that okay, we know that 5,986 people are eligible, but just 5,249 people have results. Now let's take a look at the eligibility just once again. You'll see that it has a reference, and I'll tell us why, for us in the programming sector, why this becomes important. I have looked at it till the end of June, right? So it's more or less giving me an insight into, remember, like I said before, the first quarter starts in October, the second quarter starts in January, the third quarter starts in April and run till June. So this is more or less telling me that by the end of the third quarter, I should already have this number of clients like we had before, 5,986 people who are eligible for viral load. Out of these 5,986, I already know that this number have a result, or the result will still be valid, will be less than a year by the end of June, meaning that the difference are those who are supposed to have a result by the end of June, but don't already have it yet, which we call the viral load gap. Then we know that I have between this month and the end of June to ensure that we follow up with these clients, let them have their results, now let them have their samples collected, results retrieved, and documented. So it gives these people things to work with, the gap, which will look like at in a bit. That, okay, in the next 2 months, 3 months, thereabout, these are the number of people we should be following up with that needs to have a result or something like that. And then when the time comes and then they say, okay, how many people are supposed to have a result in this facility? How many of them have it? We would have closed all the gap. Okay. So sorry, now we're looking at of those who have a result, how many of them are suppressed? So that's what, sorry, okay, it's about this. Now we want to look at, okay, we know those who are eligible and those who have a result. How many are eligible but don't have a result? So you can do this in 2 ways. The first way is the one I talked about just now. Just subtract all the total eligible from those who have a result, and it gives you your number. But the problem with that is that it doesn't give you the line list. You are not able to identify the patients. You just know it's 737. Identifying these 737 people become relatively very difficult, okay? But if you come back to use this function that is called the tx_VL eligible, and then you set the argument sample to be true, then it tells you those who are supposed to have samples collected and results received. That's about the difference between this and that. This time around, the specific patient level information. So I have the same number, 737, but now I know exactly who these people are. And then we're able to take this information and then run with it for the next few months, right? Get them to have their results and document these things before the end of the quarter. Okay. So let's look at, okay, we know that 5,000 plus people have a result. Of those who have a result, how many are suppressed? Again, if you run that and then you call the arrow function on the number suppressed, it gives you the number that are suppressed. Then the difference will be the unsuppressed. Again, if you do the difference, it just gives you aggregate information, absolute number. There's another function that we're not using right now. It's called the tx_VL unsuppressed that gives you the specific list of these clients who are unsuppressed. And then the facility already know, like I said, there are proven interventions, and they're able to tailor those interventions to these specific people and get them to become suppressed as soon as possible. Okay, so we have run a few of the viral load indicators, what I call the viral load indicators. So let's say I want to now create a summary. I want to communicate my results, and the people who need the line list already have the line list, but I need to be able to just provide a summary, like how many people are current in Lagos State, how many are eligible for viral load, how many of them have a result or suppressed. And this is one of those things we routinely do when we're discussing program performance and program improvement. You just have something like that, and it gives you something like this. So if I look at the function I just ran now, it gives you a summary, for example. So we're going to go through the arguments one after the other. So the first ones are the ... dots, like we already know in R, which is just how many of those patient level information do you want to summarize? So I want to summarize the current, I want to summarize those who are eligible, I want to summarize my result, I want to summarize those who are suppressed. Level is that it takes one of three. Do you want to summarize at country level if you are running for the whole country data? Or if you do want to summarize at state level, do you want to summarize at facility level? If I have put this at facility, it's going to give me this detail for each of the simulated facilities in Lagos State. right? And then it's going to adjourn a total. So I'm not seeing just for each of the facility at the bottom. I'll also be able to see what the total looks like. Well, I've decided to just put this at state for now. You might want to put yours at facility, and then you just see exactly how it looks like as facility level. And then the names tells you, excuse me, do you want to change the name, or do you want to have specific names for each of these indicators? So of course, the standard name that I've put at the check score, checks, BL eligible days, BL suppressed. So if I share this with anybody, it becomes very, very easy for them to make sense of this. To say, oh, Lagos State has 6,318 people who are on treatment, out of which 5,986 are eligible for viral load results, out of which 5,249 already have a result and 5,090 are suppressed. Recall the UNAIDS 95, 95, 95 targets that I mentioned before. Okay, so this treatment, because the NDR is more or less like, at least up to now, up until recently, more or less like focuses on the treatment indicators. So you can see the second 95, that's how many of those who already are on treatment, how many of those who are on treatment have a viral load result. And then you can see the third one, how many of those who already have a result are suppressed. Or basically, that's what we call the viral load coverage and the viral load suppression. So if we want to see that, you can just come here. For example, that's the viral load coverage, which talks about of those who are eligible, how many of them have a result. And this can just give me like that. Okay, let's also add the viral load suppression to this. So we'll be calling the dplyr mutate function. I'm going to put dplyr here. Sorry. Okay, and then we're going to add the viral load. Let me call it viral load suppression rate is equal to those who are suppressed divided by those who have a result. Okay, so if I run this, sorry, just double checking that everything is fine. Okay, I think it is. I'm able to see my coverage, right? And then I'm able to see my suppression rate. Okay, so the target, like we discussed, the minimum is supposed to be 95, and this is supposed to be minimum of 95. So obviously for this simulated data set, it does look like if the program has to choose between which one should be prioritized out of those coverage and suppression, they know that they're doing relatively well with suppression rate. The minimum target is 95 and they're already at 97. But the viral load coverage, the minimum target is 95 and they are currently at 87.7%. So this gives them an information, okay, we need to mop up our viral load coverage. We need to make sure that all those who are eligible for viral load have results. And then that drives them for the next couple of weeks, months, until they're able to have this sorted out. So just take the next 1 minute or thereabout to look at, okay, so why the disaggregate function? Okay. So sometimes even when you have your summary functions like this, let me just call the lagged call again. Like we said, it's just patient level information telling us about all the people who are active on treatment in the facility. But you might want to disaggregate this, maybe say by sex. You want to know how many of these are males, how many of these are females. And at this time around, we want to do that at facility level, okay? So this function helps you, and you're able to look at it like this, okay? So you know that, oh, in facility this, in this local government, in this state, this is the number of males, these are the number of females. There is another tab, a column that is called unknown, because like again, data comes from so many sources. A few of these does have missing records. So the missing records helps you to know if you also have missing records in the facility. And if the client is something you can go back and fix, you can say, oh, facility A, you have this number of missing records for this particular indicator, for this particular variable, is it sex or whatever? Go back, look at it, and let's correct these missing indicators. and it gives you the whole total. And like I said, if we look at the end of this, there is a total function, but the simulated data has 1,000 facilities in Lagos State. So we're not able to see and do all of this. So basically, that's how it works. And like I said, the vignette that comes with the package really, it's helpful to I just guide you through how to use the package for those who are in the HIV sector. But for those who are not, I hope you are also able to learn how we have been able to apply the knowledge of R to the data that is available in this space, in the sector, and how that really helps us to improve. And maybe you can pick a thing or two from that too. Okay, so this is the tidy NDR. So we'll now take a moment to look at the Achiever app. Unfortunately, I won't be able to share the codes for the Achiever app because I don't have the permission right now to do that. So I'm just going to go ahead and run the app and just show us how it looks like. So it's, like I said again, it's a shiny app. So I just run it here. And then the app takes a few minutes to come up. And then we'll put this on a server, and then people are able to have access to it across all the supported facilities. This time around, they don't need to have any programming or coding skills. They're able to look at the data there, make sense of it, and use that to improve the program. Okay, all right, so it's coming up. So like I said before, we try to create a login using some of the R packages. So you log in and then it gives you this dashboard. Like I said before, put your cursor on any of this, it will tell you the state and it gives you a quick overview of what the performance looks like. I'm eternally grateful to everybody who has made contributed packages out there that has really made this very helpful. I remember when I stumbled on the Niger, I really don't know, I think it's Niger package or something, written by Victor Odom, I think. I was fortunate to meet him on one of the previous meetup groups. But I think he's not here today. I want to let him know that its package is really helpful. It really came in handy about this time. Okay, so this gives you the summary, and then if you come to the performance tab, for example, you're able to look at what is happening. So the moment you choose country, you're able to look at which of the indicators are you looking at the attrition, is it in terms of numbers or rate? And when you click on update, it just gives you the opportunity to see the performance of facilities, okay? So it ranks them from the best performing facilities to the least performing facilities. Okay, and I can see that the best performing facilities in this regard are those that don't have any attrition. If I toggle this, then it shows me the other way around. Then I can see the least performing facilities. And then I can also come here to decide how many entries do I want to be able to see in a row. So there is a standard target for attrition. Attrition should not be more than this particular percentage of your clients. So I'm able to track all the facilities that have attrition beyond above the benchmark. And then we're able to start providing support that, hey, facility A, facility B, facility Z, your attrition rate is significantly above benchmark. Let us see how we can work on this over the next few weeks, over the next few months, or start programming around that to see how we're able to improve. So like I said, this becomes very, very handy and is available to everyone who has access across the country. So that's about the performance. So you can want to look at a specific state. Take, for example, I'm interested again in just Lagos, okay? And then I just click my update. It will give me just for Lagos State, okay? It gives me just for Lagos State, and then I can see the same thing. And it helps me to know, oh, where are the places I should put in more efforts, since I cannot support the whole of the facilities in Lagos, for example. For example, this simulation has 1,000 facilities in Lagos State. So you can imagine how easy it is to provide technical assistance to 1,000 facilities at the same time, okay? So this is the NDR. Both of these work with the NDR data, right, that are already fed into the program. So, but this particular one interacts a bit differently because it helps you to be able to see at a facility level, okay, or a state level. The moment I select country, it auto populates with all the facilities in the country. But if I select a specific state, it will only populate with the facility in that specific state, okay? And then let's say again, I want to look at Lagos State. And then I click on my update. It should present a dashboard here that shows me a summary of what is happening in Lagos State, okay? So I'm able to see at a glance how many people have become inactive in Lagos State, how many people have missed their appointment, how many people are new on treatment using the defined period, how many people am I expecting to still come for appointments during a particular period of time, and then the viral load indicators. These are practically more or less like summary of some of the most important indicators, and it just gives you a quick idea of that. For example, in this particular one, I can see that this is the number of people who are active in the state, but this is the proportion of people who are on what we call the appropriate regimen. So I can see that the gap is the number of people who are not on the regimen most, or that's the medication combination most appropriate for them. And then this is huge, it's significant, for example. And then I can say, oh, over the next 1 month, over the next 2 months, we are going to be looking at how to minimize, how to close this gap and ensure that we give our patient the good regimen, for the most appropriate regimen for them. And this is where this becomes relatively very useful. Perhaps one of the most useful functions of the app is that you are now able to download a specific line list of these patients. So for example, this facility, I can say I want to download all these people who are supposed to be on the choice regimen, most appropriate regimen, but are not, so that we can work with these specific ones and we don't have to start running through the whole of our electronic medical records to figure out who are the people who are not on the appropriate regimen. And then we can now pull these records out and figure out, do we have reasons, explanations, or how best do we address this over the next few minutes? Okay, so this is how this goes. Basically, all of this also works when you come to the NMRS. The NMRS is the EMR that is available in the facility. So what you need to do is to upload your facility NMRS records. I won't be doing that this time because I don't have any simulated data for that. So I'm not able to really share a real facility records, unfortunately. So you run the same thing, about the same thing here, and then it gives you a similar chart with what you have coming from the National Data Repository. Putting this side by side gives you an idea of what the concurrence across these two facilities or these two databases might look like. And then if you're interested in really comparing where the gaps are coming from, you can put your NDR file here, you can put your EMR file here, and then run the comparison, and then to give you a summary here of exactly where the gaps are coming from and what you need to do. There's a guide. Sorry, I'm just going to go back and share that. Sorry about that. So, just look here. All right. So there's a guide here. I think I might have to minimize this a bit for users that we can just quickly run through, and then gives them an overview if they need a refresher or something. So basically, this is how it goes. I'm aware we just have about 3 minutes to 12 o'clock, and thank you for your time. And if we could just go back and take the next round of the question and answers. Thank you.
Okay, awesome. This is really wonderful. I really had a nice time today. This so much, and I from what Janelle just posting now. Great to see Shiny. I was kind of curious that okay, where could Shiny be hiding in all this? So, but I'm really happy that you mentioned Shiny at the end of the day because we need something. Okay, an app to be around what you're doing so that it's available to those out there. So I think now we're going to take some questions now. Marvelous, you have some questions there that you want to share? can unmute yourself. Are you there? Okay, let me go out with one question. If anybody has a question, please just kindly signify. You can just say it out loud. So because I'm feeling like making myself loud here, I really enjoyed a lot today. So why, I want to ask a question. Why R? Why not Python? Why not Python? I want to know why R. You're a medical a professional. You were not forced to learn R, and why opt for R in the first instance? I don't know, because Python is kind of louder than R, and you're not in the academic section. So there's a lot that you need to answer that question for me. Okay.
All right, thank you for that wonderful question. I think that I really didn't have a choice when I started, because how did I start learning about data science? I was just browsing online that day, and then I came across this introduction to the data science specialization track by John Hopkins University, the one taught by Jet Li, Brian Caffo, and Roger Penk. And of course, it was in R, and I was interested. So I started. So I didn't even know at that moment, I didn't even know anything about Python or anything like that. So I started my journey in R. I didn't get to know about Shiny until like 2 years after that. But I became really very comfortable with using R. And when I looked at the comparative advantages over Python, I just felt, no, I'm going to stick to this. I think it's great. And a few other people who probably know Shiny, who know R that I've interacted, who know Python, who know R that I've interacted with, probably have like, okay, I understand. They probably loved R more than they do love Shiny. And I can see the development coming rapidly into R. And I just feel like, I don't know, maybe others might be comfortable with using Python, but I'm very comfortable with using R. And I think I'm going to stick to my winning team already. Why change the winning team?
That's great. Okay. I love that answer, because it's been kind of intimidating so many new users that are coming into R. When you want to talk to them, they're okay. R is easy for me. Starting with R, I wouldn't say I started with R. I started with Python, but now I stumbled on some courses on R, and ever since, life has been easy for me. Although I use Python, I still use Python. But if I'm talking about data analysis, I think R will go get the thumbs up. So no matter what. So let me give Marvelous a chance now to ask a question. Marvelous.
Let me just ask my questions. Thank you
Okay.
so much, Dr. Stephen. Your presentation was indeed a great one. I have about two major questions. So to an extent, I work in the public health space. I'm quite familiar with some of the softwares that are being used. I know that DHIS2 is one of the approved software that is used for data collection across states in the country. So, but getting to know about the R package and like the functions seem similar. Is there any difference between these two software, or how do these softwares seem to complement each other? Like, so that, in the civil service and in the private sector, we don't have parallel structures. Like DHIS2 is being used, also we are bringing in R, like so, or what is the advantage of the R package over the DHIS2? That's the first question. And then the second, I think from your presentation, you mentioned that data is being collected across facilities on HIV patients for this particular one we talked about. So are these data gotten from private facilities only, or public, or both sectors? I would just like to get clarifications about that. Thank you.
Okay, so if I can just respond to Marvelous' question, and then we'll come to Janelle, I think, and then we'll take Janelle's questions after that. So I'll start with your second question because I think it's relatively more straightforward. Facilities of public or both, I mean, public facilities, private facilities, or both. Okay, so I think the NDR reports data across almost all the facilities where HIV programming is taking place. So if you have a donor that is supporting a HIV program in that facility, data, patient level data are routinely collected, and then there is ongoing national effort to make this available as electronic medical records, whether private or public, and to have this reported on the online platform, which is the National Data Repository. This is not complete yet because the good news is that my slides has a whole lot of links to publicly available information out there that can clarify a whole lot of these things. So the NDR project started not too long ago. So it's not complete yet, but it's a work in progress. Most of the facilities, like I said, out of the about 1.3 million people estimated to be on treatment in the country, over 1 million of them are already being reported on that platform. So they come from both private and the public sector. Okay, all right. So now to DHIS2 and the NDR. Okay, so the NDR again is the National Data Repository, of course, created by the government, supported by the government. The DHIS2 is also supported by the government, okay? My own understanding is that DHIS2 came first. DHIS2 reports not only HIV program, but reports all surveillance program across the country. So you have TB, you have malaria, you have so many other diseases that have been of epidemiologic significance that have been collected, that we have data being collected from in the country, reported on the DHIS2 platform. That's not really exactly the same thing as to what you have on the NDR. For now, I'm only aware that the NDR reports the HIV program alone. But maybe the biggest difference is that NDR specifically reports patient or has patient level line list. So it's like a repository of the information about all patients longitudinally collected. Unlike the DHIS2, where what you have are aggregate summaries, number of this from here, number of that from that. You can't get patient level information from DHIS2, okay? But you can do that from the NDR. So these are a few, and the other thing is that the DHIS2 is not reported as real time as the NDR, for example. DHIS2 is generally reported at the end of the month, where summary forms are used to collect data and the summaries are put there on the DHIS2 platform. Unlike the NDR, where what you do is you pull all the patient information from your electronic medical records and put them out there on the NDR. So I think these are some of the differences. Always having a data repository, I'll give it a thumbs up any day, anytime, as opposed to having a platform where you only have summary information. So how these two interfaces, I think it's left for the people in the positions of authority to be able to say that, but they seem to serve relatively different functions in the meantime. And let's not forget that the DHIS2 is more comprehensive, it's more holistic as it is right now than the NDR. All right, I hope I'm able to answer your questions.
Yes, you have. Thank you so much.
All right.
Okay, Janelle, you can go ahead and ask your question.
Okay, so it's first of all, not so much a question as a congratulations. I enjoyed your talk very, very much. It was inspiring. And I also come from a clinical background. So I worked as a nurse for many years, and when I was introduced to R, I was told that I don't need to learn that because I work in the clinic. And I share a motivation with you in that, you know, we want to understand, we want to contribute to the well-being of the patients. And that motivation for some of us is so strong that in my case, I was willing to overcome that learning curve because it is quite steep. But one thing that maybe answers a question about why R is that currently the structure from our studio, for example, is so positive. You know, the resources that are available, you know, the kind of people who contribute and teach and share is, you know, enables people to learn. And I think that's been a very strong support, at least for me. And I'm afraid I can't speak as eloquently as you did, Dr. Stephen, when you explained why you wanted to learn, but it was very beautiful. And keep up the good work.
Thank you so much. And talking about the resources available out there, every time I stumble into a problem, I'll just Google it, and there's probably a tidyverse solution. Probably you have multiple solutions that you get. There is almost always a tidyverse solution. So I remember when I wanted to start the package, I just had to go and pull Adley's our package book, and I started reading. And then after the initial version, I was like, okay, it's time to just brush up on advanced R. Then I pulled out advanced R books. All these are resources that are just freely available, and it's just marvelous the resources that you can get added to support you. It really, really is enabling, I think. And then you have so many people you can just chat up online, and then they'll be willing to provide you the support, moral support. And I remember a few times myself and Shell, we have chatted. Shell will just be like, yes, you can do it, this, that. Submitted this for the last, the current, the user conference that is coming up. And it was more or less like the interaction of with Shell. Shell was just like, I just do it, this, that. So it's really encouraging the community out there that is available to support you. I'm just reiterating what Janella said. Very true. Thank you.
Oh, okay. I think you said so much. Is there anybody having any more questions or comments, your experience? Eniola, would you want to say something? Heidi? Hydia? I would really love to hear from you. Okay.
Oh, could I ask one, and maybe it's an outside question.
Okay.
You know, the information that you have for the National Directory, the registry, that's coming from the Ministry of Health from the government, right? Have you ever looked at like a cross-reference of the amount of medications that is released or sold from pharmaceutical companies and the amount of medication that's being used by patients?
Perfect. I like that question. It's one of those things that we really would love to. But you agree with me that looking into that will involve looking at amount of medications that are dispensed, which is what the clinical activities involve, and the supply chain that brings in these medications, right? As it is right now, information about the supply chain is not readily available. So it becomes relatively difficult to compare what is being supplied and what is being dispensed. It's one of those, in fact, my first contact with the Nigerian National Data Repository was about this time last year. And I was just so happy that finally, even though it's behind the firewall, yes, but at least we have some level of aggregates or national data out there that we can begin to make sense of, right? And use it to improve the programming. So my hope is that maybe in the nearest future, things like supply chain will also become available, and then we're able to look at that. But it's something I would have loved to. But if I may just quickly add, what we are currently trying to look at right now has to do more with, in terms of medicine dispensed, has to do more with how we integrate the medicine that are dispensed with the other services that are supposed to be offered to these clients. Because occasionally what you get is that people come for their medicines, and after a while, they realize that they're supposed to get other clinical services that were not made available at the last time they came for their medications. So they have to start calling them back to have these other clinical services. So we're interested in seeing how do we integrate not just the medication refill, but also the other clinical services that this patient should benefit from. That's some level of that information is already out there, and we can use what we already have to get some of these things done. So yes, we are looking at that.
Good, very clever. Good.
Okay. Would you want to add some comments or questions, Eniola, Hadia, Abubakar? So we really love to hear from you all.
Hello.
Hello, we can hear you.
Yes. First of all, I would like to say I'm amazed. I'm short of word for what Dr. Stephen did, and that is the beauty of R. The community, the support you get from users and package developers, like many people who have done a lot of things in R. And I'm very amazed that he mentioned issues of national data directory, because that is what we at this country we are facing. When you need data, when you need accurate data, you find it very difficult. Where will you go to? How can you, what's a reliable source? Can you hear me?
Yes,
can you hear
we
me?
can. We can hear you loud and clear.
Yes. So you find it very difficult to access data, but what he was saying today is that for we having such a kind of repository, a directory that people can dive in and get good data is a good one. And I appreciate your presentation. And we hope to see you in our own upcoming Abuja users, our next our upcoming program in statistical analysis in R. So we hope to see you, Dr. Stephen. I think Bilkisu will share that information with you. Thank you very much.
Thank you.
We're
Already registered.
Oh, excellent. Excellent. Yes. And excellent. So I just want to ask you this, please, before I go, Dr. Stephen. What are the challenges, especially with the government? You find out that, like the issue of, you mentioned the two directories, and which you explained the NDR. So is there any challenges you find it from the government aspect in terms of updates of data, government support? Is there challenges? And what efforts people in the medical sector are doing so that that kind of data, because we are in the era whereby medical data is very essential, especially in epidemiology. Look at what happened in the COVID, and look at excellent job. Like I see University of Ibadan, I can say they are the Job Hopkins of Nigeria, because I've been doing a lot in terms of the COVID, giving people information about the data, the same thing that the NCDC are doing, because so what efforts people in the medical line are doing so that they can encourage government to do more?
Okay, thank you for that question. Honestly, some of these questions are things myself personally, I would love to have somebody answer for me. Unfortunately, like I said, I am more into I'm in the clinical department and not really the
Okay.
data department. So I don't have so much information like people who are in the data department, or the one we call the strategic information. But in my own opinion, I think largely pressure from the external environment is maybe one of the things we need in Africa, and maybe Nigeria also included, to make as much data openly available as possible. Because it's just like the R itself, the R programming software itself. The reason why it's developing very fast like this is because everybody is able to contribute to its development and
Exactly.
not restricted to a few people. But if we don't have the data, it becomes more difficult to be able to contribute even if we have the skills.
Sure.
So how regularly they make this data available to the public, to everybody. I can also tell you that myself, I don't have the full access. I have only restricted access.
Okay.
And that's what you get. People with the full access are also probably not as interested in some of the things we're talking
Hmm.
about as we are. And we just continue to hope and pray that over time, because I can also tell you my learning journey in the clinical and the public health sector has not really been easy. uh, Telling people, oh, there's a doctor who knows about R, who can use R to improve things, and why R is better, or why people should also be interested in some of these things. But over time, I think with the group efforts, things continue to get better. And the other good news is, at least one of the good things that came out of COVID is it's teaching us a whole lot of things about data availability. It's teaching us a whole lot of things about data science, and now we can start leveraging on the data. I am aware of a few other projects that are coming up later this year that are more interested in using data science to mine the data we already have coming from the African continent.
Wow.
Because
Excellent.
we're becoming more and more aware of the fact that data is available. It's rapidly available to the extent at which the rate at which we're making sense of the data is not commensurate with the data that we're pouring out, right?
Exactly. Yes. Yes.
Making
Sure.
sense of the
Hmm.
data. And I think the global world is also beginning to focus on that. And they know that to make that happen, they need to start giving some level of open access to some
Yes.
of this data so that people who have the skills can look at these things and figure out what they can do with this and then use that to improve the programming overall. We have things like malaria project and all those things that now help you to map a geographical
Yeah.
mapping of malaria, things, COVID, and the rest of them. It's because they had access to open data. So
Yes.
that's
Thank you
what I
very
think.
much.
You're
Yeah.
welcome.
Oh. Oh.
Okay. Thank you so much, Abubakar, for your contribution. We really appreciate your presence. Um, any other questions? Contributions? Okay. Okay. So so if there are no more questions, I think right now really appreciate Dr. Stephen for his presence here. It was really, really interesting listening to you, looking at what you've done so far with your team. And despite all the hiccups, you've been patient with us. I'm really grateful to Jonelle, Hadia, Marvelous, Eniola, Abubakar, and
Thank
others
you.
that have not been able to come in, as well as Mashud. So I'm really grateful because it was really scary starting with the
Yeah.
hack into the webinar. So it was really disturbing, and this will be my first experience with such an issue. So I think we can mitigate that in future by having a closed access to the webinar. So thank you so much.
So we had this kind of, yeah, we've been hacked before once, and it was really such a bad experience. So now that's why we send like 1 hour before the, you know, the webinar, the link, because it was really, really bad. So I understand because I too, yeah, I was like, so, oh my God, you know, it's, but anyway, it was a very interesting webinar.
Yeah,
So thank
yeah,
you very much.
Thank you so much for staying with us and being patient. It was really not funny. It wasn't funny. It was really scary.
Yeah.
So thank you so much. Thank you so much for staying with me. And that really helped motivate me and my team. Thank you, everybody. Thank you, everybody. And
Thank you.
I look forward to seeing you all again. Thank you, Jonelle. Thanks so much. Your contribution really matters a lot. And
Good.
marvelous. I can't really thank you all so much. I'm so happy. I'm so happy that I'm smiling at the end of the program today. I'm so happy. I'm so happy.
It's okay, no worries. Thank you very much. Thank you. Bye
So I
bye.
look forward to
Bye.
seeing you some other time. Thank you.
Yeah, of course.
Yeah,
Bye.
bye. Yeah, thank you.
Bye.
Thank you, everyone.
Thank you.